Diabetic mellitus patients, they use insulin will have these idle sections. The first one, hypoglycemia. Second one, insulin allergic reaction. And the third one, very difficult problem. We still don't know how to treat insulin resistance. And insulin resistance also includes acute resistance and chronic resistance. The last idle section of insulin is the local reaction, lipohypertrophy. So let's study them one by one. And as a doctor, you should know how to treat this adverse reaction. The first one, hypoglycemia. Hypoglycemia, insulin overdose. Some patients may be, today I don't have breakfast and I still use the same dose. Maybe for other reasons, such as I'm dirty, or last night I don't fall asleep. So for some reasons, they still use same dosage insulin and their glucose level reduced and maybe induce hypoglycemia. It's diabetic mellitus patients. So at first, you should educate the patients. We only treat the disease. We couldn't cure the disease. And in their whole life, they will have several times this adverse action, hypoglycemia. So you should tell them how to treat. Because this one, in the early stage, the patients should treat by themselves. So in the early stage, early symptoms of hypoglycemia, such as sweating, tachycardia, heart rate increase, and hunger, are brought about by the compensatory secretion of epinephrine and the patients in the early symptoms. So as a doctor, in this early stage, how to treat? They can drink some cola, eat some candy or cake, yes, and eat something, and treat them by themselves, by the patients. And if they don't notice, later the worst sequelae of insulin hypoglycemia is the insulin shock. So very dangerous, very dangerous. In lots of disease, we dislike hypo. For example, hypoglycemia. The patients, yes, maybe we can use drugs, consume the life, but the damage cerebral cell irreversible. So for example, you have known how to treat hypertension. We can use antihypertensive drugs to treat hypertension, but we don't like hypotension. Why? Hypotension very low, maybe shock, dangerous. Same with other disease, and this one, hypoglycemia. The patients must know how to treat by themselves, because the worst sequelae is insulin shock. If the insulin shock occurs, hypoglycemia is best treated by administering glucose intravenous injection to save the life. The first idle section, commonly idle section for diabetic mellitus patients. The second idle section is insulin allergic reaction. If patients use the drugs and the skin rash, fever, you should know, maybe allergic reaction. And if patients have allergic reactions, to mix the bovine porcine insulin, so human insulin should be used. Very easy to treat, because I know insulin different from human insulin. You have known the reason the patients use insulin. Why have the allergic reaction? Because animal insulin. So we change into human insulin. If allergic reaction persists, desensitization may be attempted. So now we have a question. If this skin rash, mild allergic reaction occurs, which kind of drugs you can use to treat, such as histamine 1 receptor blocker, acetaminophen, loratadine. Okay, so we can use to treat this mild allergic reaction. The third, from adverse action of insulin, the most difficult problem we treat diabetic mellitus patients, because we use insulin no use and tolerance. We call this insulin resistance. Insulin resistance includes acute resistance and chronic resistance. What's the meaning of acute resistance or chronic resistance? Means the patients, they should use insulin each day more than 200 units. Do you know 200 units? One bottle insulin, 200 units. 差不多, almost here, this volume. So acute resistance, the patients, why suddenly use the insulin no use? Because stressful situation. For example, the patients have pulmonary or disease or infections. You know the reason, you know the induced factors, because they are in stressful situations. So how to treat this disease? Acute resistance. At first, you should treat primary disease. Use antibiotics, treat serious infections or water electric disturbance. You should use drugs to regulate water electric disturbance. And acute resistance, we give intravenous using insulin, very useful. So the patients use insulin no use, and in stressful situation, we change the administration method, intravenous using insulin, several days, because stressful situation disappear. Because we treat primary disease, so now insulin have good therapeutic effects. Again, we can change back. Okay. But the most difficult problem for our patients, diabetic mellitus patients, they use insulin 0 years, 10 years, and then they have chronic resistance. Each day, they have to subcutaneous inject 200 units insulin. The reason, we still unclear, maybe for these reasons. For example, in the body, have some insulin antibodies, and a combination with insulin no use. Or for this reason, decrease the number and or decrease the affinity of insulin receptors. The third reason, abnormality of some enzyme and microelement which affect the action of insulin. So still unclear why the patients use insulin no use. So we still don't have the best method to treat chronic resistance. And we have to increase insulin doses, and we should co-administer with oral hypoglycemic drugs. So later we will mention this oral hypoglycemic agents. The last adverse action of insulin, use the drugs because subcutaneous injection is the commonly using method. So local reactions. Irritation at the injection site of insulin can lead to lipodystrophy, insulin lipoma, and localized infections. For this reason, you should suggest your patients how to treat this adverse action. Change injection sites. Change injection sites. In fact, you should suggest them. The injection site should be rotated. So like this, rotate. Today, tomorrow, the day next tomorrow, rotate. And to prevent this local reaction, local lipodystrophy. Today we studied the first kind of your drugs used to treat diabetic mellitus. And most NIDDM patients, in fact, at first they use oral hypoglycemic agents. So let's study this oral hypoglycemic agents. The first case, sulfonylureas. The second case, biguanides. Number 3, sertraline. The last type, alpha-glucosidase inhibitors. So the first one, sulfonylureas. Sulfonylureas, we divide into, in accord with their generation, the time we divide into 3 generations. The first can, the oldest drug, such as this one, but rarely used in clinic. In clinic, we still use the second generation sulfonylureas, glipizide, and in this part, the most widely used is this agent, glimepiride. In clinic, the most widely used sulfonase is this one, glimepiride. And this year, we also use the third generation sulfonylureas and glycoside. And today we study this sulfonylureas, why we use them to treat diabetic mellitus. Because this drug can stimulate of insulin releasing from the beta cell of the pancreas. So what's the meaning? For IDDM patients, could we give them sulfonylureas? No use, because their beta cell be destroyed. And we use sulfonylureas to treat NIDDM patients. And just now we explained the clinical using of insulin. So what kind of patients we suggest them use sulfonylureas? IDDM patients who cannot be treated with diet alone, control appetite, do exercise, but still couldn't reduce blood sugar. And then we suggest them, use the drugs, and we suggest them use glimepiride, sulfonylureas, and also used to treat insulin resistance. Because we don't have best method, we only use insulin co-administered with oral hypoglycemic agents, such as sulfonylureas. Sulfonylureas, the adverse reaction, the patients use the drug, yes, gastrointestinal irritation, or hypoglycemic action. So same with insulin, you should tell your patients, treat the hypoglycemic action by themselves, okay? The second part, biguanides. Biguanides have 2 agents. One is metformin, the other one is fenformin. And fenformin rarely used in clinic. So in this part, the most widely used drug to treat diabetic mellitus patients is the metformin. The treatment name is glucagon. Yes, widely used in the world in each country. This drug, biguanides, metformin, makes blood glucose decreased, resulting from these methods. The first reason, the major function of biguanides can inhibit absorption of glucose from intestinal tract. What's the meaning of this sentence? Inhibit glucose absorption. Inhibit food glucose absorption. So I have a question. Later we will use biguanides to treat NIDDM patients. Inhibit food absorption. So for NIDDM patients, some patients slim, most patients that are obesity patients. And biguanides inhibit food glucose absorption. So which kind of patients you should suggest them use biguanides? Obesity, yes, obesity patients. Especially for obesity patients, the first choice agent should be biguanides. In biguanides, only one drug most widely used is the metformin glucagon. And the second effect of biguanides can facilitate glucose to go into tissue to reduce blood glucose sugar. And the third one, inhibit glyconeogenesis. And from these pathways, metformin reduce glucose level. So clinical using, just now we have known. Biguanides, metformin is given alone or combination with sulfonylureas in NIDDM patients, especially for obesity, yes, obesity diabetic mellitus patients. The adverse action. The main adverse action of metformin are lactic acidosis. It's dangerous. For this reason, metformin rarely used this year. And in biguanides, the most widely used drug is metformin, yes. The most frequent toxic effects of metformin are gastrointestinal symptoms. So doctors, the drugs inhibit food absorption, inhibit food glucose absorption. If the drugs have adverse action, gastrointestinal symptoms, such as the major adverse action is diarrhea, yes or not? Yeah, diarrhea. So the drugs, in fact, the drugs very safety, and safety, convenience, and very cheap. So the most widely used agent, most widely used oral hypoglycemic agent, still this one, metformin. Okay, biguanides. The third kind of oral hypoglycemic agents, serotonin. Serotonin, such as rosiglitazone, pioglitazone, these drugs. And these drugs can enhance the target tissues' sensitivity to insulin. So now we have a question. The drugs enhance the target tissues' insulin sensitivity. So what's the meaning? You can use this kind of drugs to treat which kind of patients? Insulin increased sensitivity. So using to treatment of insulin resistance. Yes. So we mainly use serotonin, diminish insulin resistance by increasing glucose uptake and metabolism in muscles and adipose tissues. This drug, the adverse action, later we will study, and the clinical using, yes, used to treat NIDDM patients. It is one of the oral hypoglycemic agents. Long half-life, so the patients use this kind of drugs, QD oral administration once daily, and once daily use the drug as monotherapy to treat mild diabetic mellitus patients, or combination with other oral hypoglycemic drugs, or combination with insulin, especially used to treat insulin resistance. The adverse action mild, such as edema, anemia, headache, gastrointestinal symptoms. But this drug, this year, we also found the drugs have a serious adverse action, prolonged QT interval. Prolonged QT interval. So for this reason, if you suggest this agent to your elderly patients, you should know, maybe as a contraindication. Because prolonged QT interval, the patients, elderly patients, most of them, they have heart disease. So as a contraindication, pay attention to this adverse action. The last part, the last kind of drugs, alpha glucosidase inhibitor. And the drug is acarbose. Acarbose, we have known glucose metabolism in your biochemistry class. Carbohydrate under this enzyme, alpha glucosidase, and then convert into glucose. And today, Alpha-glucosidase inhibitor mainly inhibit alpha-glucosidase, so inhibit glucose absorption. And the drug is acarbose. And the drug's safety. And the adverse action mild. So if you introduce these 4 kinds of oral hypoglycemic drugs, just now we mentioned 4 oral hypoglycemic agents: sulfonylureas, biguanides, metformin, and rosiglitazone, and alpha-glucosidase inhibitor. So these 4 kinds of patients, and these drugs, the last one, acarbose, more safety, and reduce glucose level gently. So if you use the drugs to treat NIDDM patients, which kind of patients? Mild, serious, mild patients, and adult patients or elderly patients. Elderly patients, yes, you can suggest your elderly diabetic mellitus patients use acarbose. Why I mention this? Because biguanides, metformin, like more than 70 years old elderly patients as the contraindication. Okay? So let's summarize this chapter. Today we studied the drugs used to treatment of diabetic mellitus. The first kind, insulin. We studied insulin's physiological function and pharmacological effects, includes hypoglycemic action and additional effects on amino acid, promote protein synthesis, promote growth, and increase intracellular potassium. And we use insulin to treat IDDM patients as the only agent. We also use insulin to treat NIDDM second type diabetic mellitus patients, especially for control appetite failure, or they have acute or serious complications, or they have other serious disease we use to treat these patients, or gestational diabetic mellitus. The adverse action includes hypoglycemia, insulin allergic reaction, insulin resistance, and local lipotrophy. Just now we also studied oral hypoglycemic agents. For example, sulfonylureas promote beta cell release insulin. Biguanides, the drug is metformin, especially for obesity patients. And sertraline, especially for insulin resistance patients. And the last one, alpha-glucosidase inhibitor. Okay, thank you for your attention.